Welcome to the Byja radio show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kinba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. All right, we are back, coming in hot with some more of the smooth groove from the one and only, the stupendous, magnificent, illustrious, well-rounded Mr. George Becnel, aka Patient Zero, joining us in the co-host seat today. How you doing today, brother?
Brother, I'm fantastic, man. I'm excited that 2024 is over. I'm looking forward to 2025. How are you?
I'm doing great, man. Any elaboration on why you're excited that 2024 is over? Anything specific that you just ready to just do away with, or is it just you're looking forward to new and better things?
I'm just looking forward to new, better things, new challenges, new opportunities. 2024 was a rough one, in the long run. It was exhausting. So this is one year I'm not happy. I'm not excited. I'm not sad to see go.
Just 1 year.
Yeah, this is 1 year.
got a couple others, but this one is the one that you.
Yeah, this one, 2018, 2019, and would be the two others.
I got
for
you.
Me anyway.
I got you. Okay. Well, I'm happy that we are back for episode 19. 19 in the bag is where we're going, and we are wanting to talk about a topic that was actually brought to me while I was standing at a fraternity event. It was our Founders Day, probably about 2 or 3 weeks ago. I was talking to Brother D'Artez. Shout out to Brother D'Artez. I'm sure he might be listening. So
Dave D'Artez, my guy.
Mr. President, we were literally having a conversation, and he said, he listens. He was thinking of a topic that we could cover, because I said, hey, if you have any let us know. We always looking to cover stuff that helps people. And he threw out the topic we're covering today, which is on the topic of dementia. So when we talk about dementia, it was something that I see regularly, but don't really talk a lot about it because most people don't think about it from a primary care standpoint. But it is a good topic because the world of primary care is when we are usually the first ones to hear and see about it. And then usually there is a potential where we send that or refer that to other places. Mm-hmm. But what I think we should do today is do what we've done for topics like diabetes, topics like high blood pressure, topics like cholesterol, things that are more the bread and butter primary care topics. We want to do our deep dive into what is dementia and how do you pretty much do caregiving for someone who may have it and know what to do in terms of when to go and seek help and care for those patients. So I think that's a pretty good topic to cover. And we, again, thank people for listening and engaging with us. Of course, if you're listening and engaging with us for the first time, welcome. But more importantly, like, subscribe, share, and rate this, because if we're doing a good job on the topics that you've heard, and we'll do a good job today, we need to obviously spread the word. So we're going to dive in and talk about dementia in a few different ways. So we always like to start with the basics of any topic. And the basics are just basically talking about what is it, and then more importantly, who has it. So George, I'll start with you. We're going to have a brief conversation about dementia in terms of risk factors and understanding what dementia is. So what do you think constitutes dementia? That word, people hear it all the time, but most people have no real understanding of what that word means other than some very broad, generic type of answer. So what would you say dementia is if you had to kind of give it a definition?
So from what I understand dementia to be, because I've done a little research on my diet, and it kind of led to some dementia research, is actually caused by inflammation in the brain, and it caused obviously mental and memory disorders, right? I'm looking at Alzheimer's disease is one of them, vascular dementia and others, but it affects the memory, your cognition and your behavior.
Yeah.
So that's all I know about dementia.
Yeah, and I think you hit the nail on the head. The conversation that a lot of people will hear is when they hear dementia, the first thing they think of is one of the types, which is Alzheimer's, right? Not old timers, because of course a lot of our listeners, and I'm sure a lot of our friends and family like to call it old timers disease, but it's Alzheimer's.
It's Alzheimer's.
Alzheimer's.
But I guess they call it old timers because you don't see too many young people with Alzheimer's.
Right. And you may not see it because a lot of people don't know what it is, right? They think that the only people who get this, they're old. And that's not true. And we'll talk about that in a little bit. But you hit the nail on the head with the idea of dementia is it's a progressive condition that affects the memory, cognition, and behavior of a person. So again, progressive condition affecting memory, cognition, and behavior. So what does that mean? Well, if a person over time starts to have diminished memory, diminished cognition, and diminished behavior that is different than what they've been previously, that's when we start to call it dementia. So that doesn't necessarily have anything to do with age. It doesn't have anything to do with whether a person is left-handed or right-handed. They live in this area or that. It has literally nothing to do with any of that. The basic definition is a person having a decline, more than likely, in their memory, their cognition, and their behavior. If a person is, we say that's dementia. That's the simple topic.
Sure.
So anybody can have some levels of dementia, whereas some have very severe progressive cases. Some may have mild dementia or moderate or severe. And Alzheimer's, vascular dementia, there's even something called Lewy body dementia, which we'll talk about briefly. All these are different types that can cause people to have that decrease in cognition, decrease in memory, decrease in behavior. So I hope that literally starts to lay some of the groundwork. So let's talk some statistics. So George, you got some notes in front of you. Let's throw some statistics out for the people that may be helpful to kind of give them a perspective of how many people may live with this or experience this in terms of global perspective and then more so in the United States.
So globally, you're looking at about 55 million people worldwide, which is roughly 0.7% of the global population with dementia. One person develops dementia every 3 seconds, 10 million new cases annually across the world. In the United States, 6.7 adults have dementia, and that's a roughly 2% of the U.S. population.
So 6.7 million. I think you missed the million part.
I said 6.7 people.
Yeah, just
6.7. I don't know how you have 6.7 people, but my bad. But anyway, 6.7 million people.
You round up.
Yeah. You 7 people. But 6.7 million adults, roughly 2% of the U.S. population, and it's projected to reach 13.9 million people by 2060. So it looks like it's increasing.
Yeah. And that's pretty common, right? So what tends to happen with a lot of diseases out there, you may say, well, look, this is becoming more prevalent is the word that we'll say, where you're seeing it more often. And sometimes it's because you're looking for it more often, right? If you're not screening, you're not really and truthfully going to see as many. And I'll give you a quick example how dementia kind of fits into that category, that over time we're seeing more numbers. A lot of it is because we're recognizing it a lot better and we're looking for it in the right places. And we're experiencing that, hey, these people actually do have this, whereas in the past we thought it was something else. I had this quick story that I was working at the hospital system here. And back when I did my fellowship after residency, I went and did fellowship in Washington, D.C., and one of the fellowships was in HIV care and hepatitis C care.
Correct.
So learned all about how to take care of people with HIV and hepatitis C and get people treated and have them healthy and happy. Come back to Baton Rouge, start working. And I had one of the people that I work with, a colleague, and the colleague said, well, why are we doing all these screenings for HIV in Baton Rouge when they don't have a lot? And when I tell you...
Who don't have a lot?
Exactly. Your face says exactly what my face said. And this was roughly 6 years ago. And I tell you, in that conversation, I looked around and was like, you joking, right? And he was absolutely serious. This is a medically trained physician who had, quote unquote, the responsibility of teaching people. And his words were, in Baton Rouge, why are we screening all these people in this community when there's not a lot of it? And I literally just said, this is why we need to learn and educate us, meaning the doctors, to eventually educate the community, because this is why people get misdiagnosed or go without being properly diagnosed. And that can be an issue. So dementia is very much like that. People tend to write it off as something else, and they're not properly checked, screened, are identified in a way where people can come out and say, I know I have the right diagnosis, therefore I'm getting the right treatment. So that's where the prevalence comes from, to where it's increasing. We're looking more often, we're screening appropriately, whereas in the example I just used, if we don't check for it, you're going to easily say there's not a lot of HIV around in this area because look, we're not really checking for it.
I'm about to say Baton Rouge might be the HIV capital of the country.
We're in the top 5 easily.
Like consistently.
Consistently, yeah. New Orleans and Baton Rouge are usually in the top 5.
That I-10, that dirty I-10, huh?
I will say not the cleanliness that you would expect on the interstate, both from a disease standpoint and then just trash, which is a whole nother conversation. So we need to do better. Anyways, all that being said, so that's where that prevalence is coming from. So with that, we're moving into what causes potentially dementia. Okay. And I say what causes, there are going to be a lot of things that we like to identify that can cause it. Some things are going to be easy to identify. Some are going to be not so easy. And then some of them are things we can possibly have an impact on.
Sure.
And some we can't. So we'll talk about some basic risk factors. So George, I know you already know at least one of them. You already mentioned another one. So you've said 2, whether you thought you were doing it on purpose or not. So what are the 2 most common things that may cause dementia that you can easily put at the top of the list?
Well,
1, 2.
I think I said inflammation in the brain.
Okay.
I also mentioned your diet.
Okay. So that's the diet is literally, I'd say, a second thing, right? But the first thing and the most common thing, and we talked about it and you might have missed it, what is the disease that people call it and they say it wrong?
Oh, old timers.
Okay, so why do you think they do that? Because it's usually affecting who?
Elderly people.
Elderly people. So age is the most common thing.
Right.
Age is the most common risk factor for dementia. As you get older, the brain stops working the way it should, and you start to develop dementia, meaning a decline in cognition, a decline in memory, and a decline in your behavior.
So stop. What do you mean by not working properly?
So there's different things that can cause the brain not to work properly. Some of it you just talked about. Your diet is bad, and when the diet is bad, it affects the brain negatively. Also, if your diet is bad, it affects blood flow to the brain. And when you have poor blood flow to the brain, you have poor brain function. Poor brain function means it doesn't function properly, which can be a sign of dementia.
Gotcha.
So the idea of blood flow is one thing. Another thing is diet. Sometimes it's trauma, traumatic brain injury. You had a wreck, you hit your head on the steering wheel, you got ejected from a car, you got hit in the head with something, you had a lot of concussions. All of these things are what? Signs of brain not functioning properly.
Sure.
So that's going to cause a decline in that cognition, that memory, that behavior. So those are some of the risk factors. So age, trauma, blood flow not working, which can end up happening from different things like diet and things that you're doing. And then we have 2 other ones that I'm going to point out that are very simple, very easy, and people sometimes are surprised when I tell them this is a thing. So one of the most common risk factors for dementia is inactivity, meaning you don't do anything other than sit down and watch TV and literally do absolutely nothing. You may feel great at the moment, but believe it or not, your brain is going to be affected down the road because it's not working, not actively engaged. You don't have to do a whole lot of thinking when you're watching TV, right? So at that point, you're really and truthfully going to start to see a decline down the road. So inactivity is one, and I say TV, but that's an example.
So I'm gonna challenge that example.
Yes.
And I'm not defending people who just sit on the couch and watch TV.
Okay.
But my question is,
yes,
wouldn't the content maybe affect that? Because if I'm just sitting there, I feel like for me personally, I can speak. I can speak to this. If I'm sitting there watching Family Guy and just being there, then I'm pretty sure there's a low brain activity, right? But if I'm watching like a documentary, or if I'm watching like a thriller where I'm trying to figure out who was the murderer, or if I'm watching some MSNBC where I'm trying to learn some things, I would assume that that's not the same level of brain activity.
Yeah, I'll say that you're on to something, and the theory of what you're saying is which TV watching is the least problematic. I think that's fine, because if you're comparing very, as you said, low brain activity watching versus stimulating brain activity, a game show where you're really trying to get the answer right kind of watching, I think those are potentially going to be on one end of the spectrum. compared to you getting out and bike riding and having to now navigate pedaling, steering, not getting hit by a car. Like your brain's a lot more alert when you're riding a bike compared to you're watching TV. Your brain's a lot more alert when you're exercising.
Okay.
When you're getting out and having a conversation with a friend, your brain's doing way more activity, way more work recording a radio show.
Sure.
So I'm helping your dementia right now. So my idea is that
my future children, thank you for that.
So that's the whole point. The more you're actively engaged in stuff, your brain's going to do more work. The more work brain does, if you don't use it, you tend to
lose it.
So we're trying to obviously tell you some of the things that are simple. Of course, age and all that. You may say, well, I kind of knew that. But when I tell people, if you're more active, your brain potentially lasts longer. People are surprised because they didn't correlate those two. They know the heart works better, right? They know that you potentially have more stamina, but they didn't think the brain stays healthier longer. So that's something I'd like to point out.
So I want to clarify something you just said, or at least get you to touch on it more, because I think you made a big point without realizing it. So something that I would have assumed, I thought it would be more brain activity by doing something mentally challenging or learning something mentally challenging, like picking up a new topic that you've never learned before, or sitting in class. But you just said riding a bike might be more stimulating, even though it's something we all can do. It might not challenge you intellectually, but because of all the different factors that you have to pay attention to,
stimuli,
all the stimuli, that might be better exercise for your brain. And I kind of want you to talk about that a little bit more.
And I think it's all on a spectrum, right? Like I said, some people may not be able to ride a bike at this point, right? They're older, they can't do that. So yes, there are some things that are going to be more stimulating than sitting there watching a sporting activity where you don't have to think as much. Hey, let me read this book. Let me do these puzzles. Let me do something that literally engages my brain more than just watching this movie I've seen 700 times because it's really good.
So coming to America is not good for your mental?
I will say after the 48th time, because I think you're on 462.
I've probably seen it 700 times at least. Yeah.
So, but the point is, yes, it's going to be joyful for you to do certain things that really and truthfully become second nature. But at a certain point, it starts becoming second nature because you know it front and back. You know it that well. You don't have to really stimulate your brain to figure out something you've never done before. So picking up a new book, a new activity, a new show, a new puzzle literally makes your brain start to do more work when it hasn't basically seen it before, right? So the physical activity is one thing that helps, but physical inactivity hurts.
True.
Other things that hurt, as you said, diet, but let's go a little bit deeper. So people who oftentimes have things like high blood pressure, diabetes, and cholesterol issues tend to have more problems and being more at risk for developing dementia. People who smoke a lot have more risk factors for dementia. And of course, people who have heavy consumption of alcohol have more risk for dementia. So it's, again, everything's in a spectrum. It's not saying you can't have your, good meals and celebratory drinks and things of that nature. I'm not saying that, but everything has to be in moderation. If you're doing too much of one thing and not enough
of another thing,
you're going to have problems, right? So all of that being said, those are some of the common risk factors. Now, I'm going to add a few more on there that a lot of people also may forget. Depression and being isolated.
Sure.
So all of the introverts out there, I encourage you to try to do things that are going to keep that brain stimulated as much as possible. And then again, believe it or not, being around other people can oftentimes help that. So depression and social isolation can lead to more risk of dementia. It doesn't mean that if you're socially isolated or depressed, you're going to have it. It just means you have a higher risk of getting it.
So, question back to the diet. Question for you. The type of foods, obviously you want to eat healthy, right?
Yes.
You don't want to eat a whole lot of fat. You don't want to eat a whole lot of sugar. You don't want to eat a whole lot of sodium. That's just healthy just for anybody, for life, right? But when you're talking about dementia, in particular, is there a certain diet you should follow, or are there certain foods that could help, or should you be eating foods that cause less inflammation or maybe go against inflammation? Like, what are your thoughts on that?
Yeah, I think it really does come down to person by person. There's no generic diet of this is the diet you eat and you're less likely to get dementia. It's more about your health overall. As we just mentioned, if you're physically active, your heart's good, you're not taking into account certain things that you can't control, which we didn't talk about. But like you said, age, you can't really do anything about that. Your family history, you can't do anything about that, right? And then your genetic makeup, you may not be able to do a lot about that. So all of those things are going to inform and affect your diet. Some people can't eat certain things, even though it could be healthy from a dementia standpoint, but you can't because you're allergic to it. So at that point,
like, what do you do?
Yeah, what do you do? So I think it does go into, yes, some diets are probably going to be better, but the main concept is to avoid disease and avoid inactivity. If you can avoid the disease states that lead to progression of these risk factors, high blood pressure, diabetes, cholesterol, poor blood flow to the brain, all these things that are going to be risk factors, then we're going to have a better time that we're avoiding this potential life-altering disease. And other things that we talked about briefly that can be risk factors, again, genetic makeup, where certain people just have certain genetic markers that are going to be a predisposition to a dementia, and then of course family history. If you have people in the family who continuously develop this, you're more likely going to develop it, and you can't do much about that. So we kind of break it down into modifiable risk factors and non-modifiable. If you have a lot of modifiable ones, let's do what we can to get those eliminated so we are less likely to have it. So we'll move on to a few other things, and then we'll talk more about what most people want to know, like how do you find, diagnose, and possibly how do you treat it. So let's talk about some warning signs, if you don't mind. So
sure,
George, I'll ask you, what warning signs jump to the top of your proverbial list that you would say, hey, if I see this, I start to wonder if a person may have dementia, or if not have it, they may be starting to develop it. Are there any things that you would say are key signs people need to look out for? Because they may have a family member, they're listening to this episode, they're wondering if a person has this and they're not sure, and they're wondering what to look out for. They think about it, they feel it, but they're not sure. What signs would you say, yeah, if they have this, this kind of gives you a cause of concern?
So for me, I would say, behavioral changes would be number one. If you have a family member that's been one way for 70 years and all of a sudden they just change on a dime, that would be concerning to me. Or certain things that certain things that you would do or that you've done your whole life, and you've all of a sudden forget how to do those things. In my opinion, that would be a warning sign for me, right? You know what I mean? Let's say, like you and I, right? You and I go hang out, and for some reason, when we get dinner, you don't order a cocktail or you don't order something with some type of bourbon in it. I'm gonna be like, wait a minute,
who's this guy?
Marquis, you see this? Like that would be my thought process, right? So just, I guess, extreme changes in somebody's behavior or routine for me would be like number one. Or maybe memory loss, things of that nature.
And I think those are the two ones most people know, right? Hey, they're acting differently. And that's not something that's usual for them, right? They used to always love this show. They love this song, and all of a sudden they could care less, right? That's one thing. Hey, they're also forgetting a lot of stuff that I've asked them to do, or they normally would remember, they're forgetting it. So those are the two most common things that you would say kind of are warning signs, okay? I'm going to add one more, and then I'm going to throw it back to you to basically figure out if this is something simple that you may not necessarily realize, but it is slightly different than what we just talked about. So difficulty solving problems. That's one of the big things we look out for. And you may say, well, what do you mean? Sometimes people have simple problems that they can easily solve, and you don't even think about it as a problem because it's so easy. But then sometimes you have to give them an actual challenge, right? And a challenge, which we'll talk about when it comes to diagnosis, makes more sense for you to kind of put the theory to the test. You feel like they're confused. You feel like they're potentially having memory loss, but you're not sure. So why not just test it? Simple, right? That's an easy way to see if your warning signs are truly something that are there versus, hey, I asked them this and they actually got it right. And I didn't think I thought it was something that was going to be a problem, but now I'm realizing maybe it's just me. So I think that's it. So the one I'm going to kick back to you, and I actually said it out loud, so I apologize. I actually gave you the answer, but you said memory loss, and you also said that they are having changes in behavior. I said difficulty solving a problem. So is there one other that you would say that could stand out, that may be something that people easily can say, yeah, this happens a lot?
Repetitive questioning. You know, like if you ask a question and I answer it, and you come back and ask the same question.
Yep.
You know, that might be concerning. I guess that kind of go hand in hand with memory loss.
So memory loss, but it also comes down into confusion, which is what I actually said out loud. It's to the point where they're getting easily turned around in their mind, right? You can easily say go left, and they're literally looking at you like, what do you mean?
Yeah.
And you're like, no, it's simple. Go left.
Right.
And they don't understand. And you think, oh, man, it's just a little brain fog. But it's confusion because to them, left may not necessarily mean left anymore, right? It may be that they're thinking they're going left when they're really not. And you're looking at them like, what's wrong? So memory loss is easy because you'll say, well, they forgot something. Most people can wrap their head around that. Then you can also have an issue where a person has behavioral changes, as you just said. They don't want to watch the movie anymore. They don't want to go to this place anymore. They used to really like this. They don't do that. So those two are easy. The two we just mentioned, them being confused all the time, that's really tough. And then the other one that most people don't even think about is just give them a problem and see if they can solve it. Something easy, right? And we'll talk specifically what is an easy problem. But if you can
that was my question.
Yeah, if you can find that simple, easy problem, and we'll give you some examples, and the person can't get it, that's probably a huge warning sign, like something's wrong.
I'm about to say, because I need to know what's an easy problem.
Yeah, and
because if you hand me a Rubik's Cube, like right now, I don't have dementia, and I'm probably not going to fix it.
Yeah. So those are the common warning signs. So if a person you love or a person who's near and dear to you is having behavioral changes to where they're kind of acting differently, they're not remembering things the way that they used to, or they're not enjoying things the way they used to, that's one big sign. Memory loss, as George mentioned, repetitive questioning because they are possibly forgetting that they just asked this. And then they're also having difficulty with solving problems or confusion. Those are our warning signs that we kind of tend to look for, especially on the medical side. I'm going to ask those questions if you come into my exam room and say, I'm worried that this person has dementia. I'm going to ask some of those things. Are they having issues with memory loss? Are they having issues where the behavior is changing? Are they having confusion? And if a person has all of that, then we're going to obviously make some changes. Now, this is the very last thing I think we'll talk about in the first part of the episode. What are the misconceptions of dementia? One of the major things people tend to have really wrong about dementia is, look, as I get older, I'm just going to literally start to have this problem. It's just a part of getting older. That's not true. That's not true at all. Why is that not true? How many people, and this is a question for you, George, that you can easily say they are older, and I mean older in the sense of they're in their 80s or 90s, and they're still sharp.
Yeah.
They know exactly the date. They know their appointments. They know where they're going. They know their family members. They know all of these things. And you're like, this person's 90 something, maybe 100. And they still are very healthy, happy, and functioning.
I know a lot of people like that.
A lot of people like that.
Right.
So why do we not say to them, this is weird, right? You know why we don't say that? Because, I'm sorry, I said that backwards. Why do we look at them as being weird when they're sharp in their 90s or 80s? It's because we're at a point where we start to think losing that mental faculty is actually normal. It's not. Right. You don't want that to happen.
Because we compliment people when they're still sharp. They be like, "Hey, look, you still sharp as I don't know what." And it's almost, I guess, it's almost insulting.
Yeah, it's a kind of a backhanded compliment because it's like, when you're getting older, I'm expecting you to lose it. Right. I'm expecting you to be less independent. And that's not the way it should be. We, in the medical side, especially me, I'm constantly telling people, my goal is to get you into your 80s and have you then say, I got 20 more years to go. That's my goal. If you get into your 60s and you starting to break down and I'm literally hard on you, it ain't because, well, you 60 something. And no, I'm literally talking to you like you're 50 or 40 because 60 something is just beginning.
Right.
That you should have 40 more years if you're hitting your 60s. Easily.
Yeah.
Should. But if you're like, well, I'm getting up in age, you're not. That's a mind thing. That's a physical mind thing. And I say physical mind, meaning your physical feeling and your mind, the feeling of those two things should be to the point where you are getting better and healthier. But as you get older, if you start to think, well, it's normal for me to forget stuff. Well, it's normal for me to get confused. It's normal for me to have the issue where my behavior changes. That's not. So we need to figure that out early and talk about treatment early so we can try to start reversing these processes. And then if we can do that, people tend to live better, longer, healthier, and happier.
Well, the reason for that, I think, as a society, and especially as a community, right, we are used to being unhealthy.
Mm-hmm. I agree.
And that's with a whole bunch of things. And I don't mean to take this thing off the rail because I want to stay on topic and talk about dementia.
No.
But in our community, once you get to be an adult, it's almost we expect you to be like a type 2 diabetic.
Mm-hmm.
Or once you get to be an adult, we expect for you to be on high blood pressure medicine. Or we expect these things in the community where, just take better care of yourself and maybe have the expectation where that's an outlier instead of, being the norm. And I think dementia is no different. Like you said, we expect our elders to start to lose it when it's not natural.
Right. And I think you're hitting some of the points that a lot of us don't necessarily want to say, but we should. We should not expect to be on the decline when we hit a certain age. It
Correct.
should be that going on a decline is a surprise. And we need to have a concern for it and do something about it sooner rather than later. And the last misconception I will briefly touch on is that we want to distinguish, and we're doing that kind of sort of today, what's the difference between what they call a mild cognitive impairment from a dementia. Dementia is kind of the severe case, right? We're having trouble with behavior, we're having trouble with memory, we're having trouble kind of forgetting things that should be simple and easy to complete, versus mild cognitive impairment, which is like, this little small thing that happened that one time. Mm-hmm. So those are two different things. So a person thinking, well, as I get older, I'm going to start to basically decline. Let's go ahead and bust that myth. And then, of course, mild cognitive impairment doesn't mean a person has dementia. So if a person literally forgot their keys one time and they're in their 60s or 70s, doesn't mean they need to be in a independent living facility because now they can't drive no more. That's not what we're talking about.
And you got to factor in what kind of day they had and all this good stuff. Like, you still got to give people grace. Mm-hmm. Right?
Yep.
Be concerned about people, but let's not be dramatic.
Yeah, I agree. And I think you're touching on something that sometimes we'll have people come in, they'll bring their elderly relative or family member or friend, and they're worried about something. And I do some of the things that we're going to talk about. And as I go through those things, people say, oh, well, yeah, they're fine. I'm like, yeah, they seem pretty normal to me. It's just to the point where they're concerned because of one thing happened one time. Now, if it becomes a common thing, that's when we start to talk about treatment and recommendations. But if it's a one-time thing every 4, 5, 6 months, people are going to be people, right? You're going to forget some things. You can't remember it all.
And look, and I applaud people for checking on your loved one, because a lot of people don't have that person to check on them like that and to be concerned for them. So I'm not making light of that or making fun of that. I mean, that's a good thing, right? But sometimes just have a little bit more grace. You know what I mean?
Absolutely. So that'll take us out of the beginning section of this episode. So if you're listening this far and you like what we're talking about and like what we're laying down, please subscribe, please share, please rate. And then, of course, follow us, all that good stuff. And why am I saying it in that way? Because when I looked on some of the platforms that these episodes are posted on, I was shocked that we have so many good ratings, but I was also shocked that we didn't have so many more, because I've had people call us, email us, text us, and tell us we really appreciated certain things, but they're not liking, they're not subscribing, they're not sharing. So I'm definitely going to plug that in this moment between section 1 of this episode and section 2. So if you have not done so, we would like you to take whatever platform you're on, give us a positive comment, like, subscribe, share, all of the things that help us get these messages out to people who need it and need it most. So we're going to move on to the second part of today's episode, which is going into very simple, very straightforward. How do you screen for the dementia beyond what we have talked about, which is the simple things that we're looking out for from a warning sign standpoint. And then, of course, from a risk factor standpoint, how do you go beyond that to start doing a diagnosis? So in short, what I would say from the primary care side, you're having the concern, you've identified the warning signs, you're not really sure, but you want to know if a person does have dementia. What do you do? Well, hopefully you have a good primary care doctor and you're going to bring that person in to see that primary care doctor. And that primary care doctor will do what we call screenings. And the screenings are going into basically simple cognitive tests that can be done, that don't really cost anything, but you have to know how to administer them in a very simple way. And some of these tests involve you as the caregiver. It involves the person, of course, and then some of them are going to be person only, where you have absolutely nothing to do with it as a caregiver. We're administering the test to that person to see how they perform. And one of the tests that we do, and it's a simple test, you can look it up if you want. They're free. You can probably find it online. And I do not encourage you, if you're not a medical person, to try to do this. And it's not because it's hard. It's just because if you do it wrong, it's going to freak somebody out. Okay. Right. It's called a mini mental status exam. A mini mental status exam. If you Google it or you search for it, it'll pop up, and it is a PDF document that has a bunch of questions on it. And the mini mental status exam has some very simple questions. So George, you asked earlier, what are some of those screening questions that are simple problem solving questions that we would say a person should do? So I'm going to actually give you a couple right now. Okay.
That's why it's not in my notes.
That's why it's not in your notes. And it's something that can tell me if you have potentially a warning sign or a concern for dementia. So
I'm low-key afraid.
You should not be, because if you do not have these, and these are not hard questions, if you don't have these, then I would be surprised. Okay. But this is really hard for people who have dementia. And it's not because they're going to give you this really frustrated yelling, screaming, and hooping and hollering. It's going to be where you can just see that they just can't get it. Okay. Mm-hmm. So first question.
All right.
What day of the week is it?
Friday.
Simple. All right. And that's simple question because it's Friday. Right. Mm-hmm. And then the next question usually is simple. It's orienting the person to time, place. Okay. So time is simple. We say usually day of the week because that's a time. Right. You don't want to say what time of day is it right now, because of course a person may have a watch on. So that can be hard. But orienting them to a date. What year is it?
2024.
Simple. And that's a problem, because believe it or not, some people with dementia, they don't know what year it is. They know they're here. They know they're functioning. But if you say, well, what year is it? I've had people answer it's 2000. I've had people say it's 1980, fill in the blank, and we're in the 2020s, right? And that's tough because to them, they don't know. And they're telling you an answer because they think it's right versus just saying, I don't know. Now, some people will tell you, I don't know. And that's a warning sign that kind of lights the bulb of something's wrong, right? So we talked about date and we talked about day of the week. Okay.
Sure.
So another one is, tell me where we are right now.
We're at J. Kimber Executive Suites.
Right.
In the conference room.
In the conference room.
That you can rent out. Shameless plug.
Shameless plug. But hey, we do need these coins. Okay. So if you do need a place to rent, we have a great conference room. Very beautiful. But I digress because we're also trying to be educational, but that is orienting a person to the place they're in.
Sure.
Okay. And you'll say, well, why can't I do this at home? I'm not saying you can't, but again, you don't want to do it in a way where you're asking a complicated question of, well, tell me what year was the year that you got married, and all of a sudden you're freaking the person out because they don't remember their anniversary. I mean, as much as that may sound like a good idea, it needs to be very simple.
And a lot of people don't remember
that, right? Yeah. So you don't want to get to the point where you try to overdo it. So
correct.
Orienting a person to time and place is simple. What year is it? What day is it? Where are you right now? And if a person is in an exam room, they usually can say, I'm in a clinic, I'm in a hospital, I'm at the facility if you're in a medical facility, right? It doesn't have to be complex.
Sure.
If you're at home, the person can say, I'm at home, okay? If you're at a grocery store, they should be able to say that. But if a person can't answer those 2 to 3 simple questions, that is very early part of the mini mental status exam. And just now, George passed with flying colors. I'm going to honestly tell you, if you're listening this far, he didn't even really try, right? He was actually just showing off a little bit.
Hey, I tell you what, had I failed, this would have got edited out the episode. I'm just
really quickly. No one would ever know you.
They would have been like, wait a minute, was that supposed to be a test? Oh, that would be cut.
Just random music, instrumental. I got you. So those are simple questions. A few more quick questions, and we're not going to ask these because it can slow things down, but another couple questions. It's called short-term recall. And short-term recall is saying, I'm going to give you 3 words. You tell me the 3 words right after I tell them to you, right? So common things, apple, penny, table. And a person would say them right back. Believe it or not, people with dementia can't do that. Mm-hmm. They just can't recall simple things. Then we have long-term recall. I say, okay, those 3 words I just told you, I'm going to come back and ask them to you a little bit later. So we'll then do the rest of the exam, and then we'll come back at the end and say, what are those 3 words I told you?
Yeah, I might have failed that.
And that's why I said, if you don't know how to do it, you're going to freak out. But you want to give it done. You want to give it to the person in a certain way where it's hopefully easy to remember.
Sure.
Right? It could be chair, ink pen, computer, right? It could be 3 different words that are easy to remember, but those 3 words are ones that we often do. Short-term recall, long-term recall,
Sure.
or orienting a person to time and place. And last thing is doing simple tasks. I'm going to give you a word and I want you to spell it forwards and backwards. And you may say, well, that's tough. True. Now, why is this difficult? Because it's supposed to be. It's a test. It's an exam. We don't want it to be all easy questions. We want some hard. We want some difficult. And if you give them all easy questions, you're like, oh, they're fine. And then something happens. They're going to say, well, what happened? Well, I thought I was the medical professional and I could do it myself. And I ended up asking the wrong questions and giving answers that I thought were okay when I realized I missed the big stuff, right? So spelling a word forwards and backwards is often a really good test to see if a person has issues with cognition. And then memory, when we just said, I'm going to give you 3 words, tell me now, and then tell me in the future. These are testing the things that are possibly the warning signs, right? And those questions are simple, easy to administer, don't really cost a lot, but they need to be done in a very specific way. And that mini mental status exam, if I remember correctly, it can be anywhere from 10 to 20 questions, maybe even more than that. And it's very much written out for you to administer. And once those test results come back, to us in the medical field, we determine if a person needs more testing or they need more specific testing, because that may be a very good opening test, but then you need to confirm it with some additional testing. Okay, so I'll pause right there and tell me your thoughts on that, George. Does that sound like something that makes sense in terms of trying to get a person to go from, I think something's wrong, I'm not sure if it's just a mild cognitive impairment or if it is a true dementia, I don't really know which way to go. How can I get into a space where I know I'm in the right ballpark? What do I need to do? I think saying, hey, you need to get into a primary care doctor's office and get that mini mental status exam is easy steps to follow.
Absolutely.
And if you're not sure you want to go that far, you can try to do some of it yourself. But if you're doing it and then something is not necessarily correct or done correctly, you can then go further. And that's a good way to kind of do both. If you don't want to necessarily go to the clinic and spend the money, if you will, because it's going to cost you money to get in to see that primary care doctor, you can do that, some of those questions at home and see if it's at least giving you the, I do need to take them in to get a full test done. If not, you can definitely say, look, I think I'm okay. But I want to know your thoughts on that. Does that sound like something that's easy or manageable?
No, it definitely does. And that's something that you should always reach out to do, right? If you see, it's just like the check engine light on the car, right? If you see the check engine light, you don't ignore it. You know, if you see some symptoms, bring your loved one in. Make sure they go, because I know some of our elders could be a little stubborn.
Yes.
Right. So you make sure they go and they see somebody. Bring them to your primary care physician. Mm-hmm. Hopefully, you have a relationship enough with their primary care physician or the clinic to where you should be able to get in pretty easily. But also, you know, you should have a relationship enough with your doctor to where your doctor might notice some of this stuff too.
Absolutely.
Just without you even noticing it.
Right.
You know, if you're having consistent enough conversations with your physician, like I do, you know, your doctor may notice some of these things because he or she is trained to notice these things.
Absolutely. And I will add on really quickly that the mini mental status exam, which is the one that a lot of people will easily find and know of, is one of many. There are also ones that are what we call caregiver or informant based, which means that a person who's watching and administering this potential mini mental status exam at home, you're considered the caregiver or the informant, the person who's identifying the problem. So you're going to be involved in some of the questions in one of these other exams. And then the mini mental status is more of the person who's dealing with the dementia or the cognitive concern themselves. So there's a variety of different tests that you may want to go and have done, but it depends on who's involved. If you're a person who doesn't necessarily stay and live with the person, but you're the person who brings them to their appointments and don't really have that overall relationship, you may not necessarily be the person to give the advanced examination to, because you're not going to be able to give the most authentic and valuable answers. But if you're a person who is a caregiver, you're spending a lot of time with them and you're seeing these changes, you being involved in the examination that we would administer is there. And there's different kinds. There's the mini cognitive exam. There's a general practitioner assessment of cognition exam. There's the Montreal cognitive assessment. So there's a bunch of them. All of those things come together where you kind of start to figure out which one works best. and which one should be administered. And once you get those done, then that kind of tells us, hey, we need to go further and do different things, whether that's imaging, whether that's blood work, or both. You may go from just doing a questionnaire and filling things out and having a person perform the exam in front of you and see how they do. And if it's really warranted, you go further and do more testing, more evaluation, and more details of that. So I think that's going to be kind of where we're going to leave it. We're not going to go into the ton of weeds into trying to tell people how to diagnose dementia at home, because it defeats the purpose, and it can also be harmful because now you're doing too much and stepping into a role you probably shouldn't be in. But you do want to have an idea of what's going to happen when you walk into the exam room. And then if a person says, well, we're going to do a mini mental status exam, you may already know what's coming, and the person who's doing it may not. And that allows you to kind of sit and observe and make sure that what you're saying is being heard, but also the person's getting a fair evaluation rather than you walking in. You say, I think the person has dementia, and they just give you a prescription. They don't evaluate you. They don't do any conversation. They don't really understand what's going on that's causing this. They just medicate. And if that's happening, then obviously you need to find somebody else. But at least you'll have an idea that, hey, they're going to do this, and I know this was coming. I heard about it on this amazing podcast with these two amazing co-hosts. I may not remember their names, which is a sad thing, because at this point you should.
Yeah.
But in the event that they don't, you can at least know that that's coming. So outside of that, we'll kind of talk about how do we go one step beyond if we're at a point of, hey, we're worried about a person, they're getting these warning signs, we're concerned that they may have dementia, and we're not sure how to address it. What can we do to try to alleviate some of these problems? So what are some preventative strategies that a person can do? Well, we already touched on it when it came down to the risk factors. So of course, eating a better diet, regular exercise, and then, of course, trying your best to avoid really bad behaviors, like you said, excessive alcohol use and even tobacco use. Those things are going to be potentially problematic down the road. It may not be problematic in the first part of the life, in your 20s, 30s, 40s, but as you get older, you start to notice that these things are happening. Pulling back on them may give you a lot better time frame of, hey, I'm not going to develop these negative mental health effects and dementia-related effects. Those are going to be two different things. Other things to do. You'll hear a lot of times when people get older, they start doing puzzles. Believe it or not, those are actually really good to do early, right? Trying to find things that are going to make you actively engage your brain to do stuff. So sometimes people are playing games that are seemingly simple. Now, what I mean by playing games, I'm not saying the slot machine. So you sitting there pulling the slot machine is not the game that I'm talking about. I'm talking about things that you're trying to literally do math and put things together that otherwise you wouldn't normally see. Crossword puzzles, Sudoku, all of those things are usually a little bit better, especially for people who aren't able to get out and do those activities because of other reasons, heart problems, injuries, a lack of mobility. They still can do these mental faculty puzzles that can be helpful. Reading is another huge one. Reading is another huge one. Reading is another huge one. A lot of our patients, I'll ask them, when's the last time you read a newspaper, a magazine, or a book? And people look at me like, wait, what? Now they'll watch social media. They'll swipe all day. They'll scroll all day. But if you tell them to read something, it's an attention span that is very short. And why is that? You have to build endurance of reading. If I literally had you read a 50-page book versus a 5,000-page book, I'm pretty sure you'll get tired of reading at a certain point if you're not used to reading. But if you're used to reading on a daily basis, 50 pages starts to be really small because you're now reading at a faster rate. You're comprehending at a faster rate. You're understanding at a faster rate. So reading is a really good mental exercise, especially reading new content, not reading the same stuff you've read over and over again.
So you're saying I should read?
Maybe just a little bit. Just a little bit. So
it's good stuff.
Now, the reading part, again, it's not just reading. It's reading stuff that's going to challenge you. Meaning, if I literally gave you or somebody who's listening to this podcast a book that is literally at a second grade level, and they're not a second grader.
See Cat Run.
Oh, well, I read. Well, kind of you did. But that's not going to help you if your goal is to keep your mental sharpness there. You need to read stuff that challenges you, right? So that's why sometimes magazines, depending on the magazine you're reading, can be helpful, because a magazine, if you're reading one that has tons of pictures and not a lot of words, that's probably not what we're talking about. We're talking about ones that have articles that are really and truthfully going to challenge your brain to comprehend what it's saying. So reading is a huge one. Learning new skills is another one. So if you can get somebody who's older to learn something new and put that to use, that can be another helpful thing that will get people to hopefully fend off this concern for dementia. And lastly, being out and about and having ties to different things. So one of the things, believe it or not, a lot of people will often say is that people who are going to social clubs, religious activities, things of that nature, oftentimes have less health concerns from a mental health and a dementia standpoint. And a lot of that is true because, again, they're engaging with people on a regular basis. They're not isolating themselves. They're not staying in the house all the time. They're out and about. They're socializing. They're in different clubs. And I'll give you an example. You're at the church or involved in all these ministries. That allows you to, again, start to challenge yourself, having to read different stuff, having to have different conversations, having to solve different problems. That allows you to have more strength in the idea of, hey, my brain is going to be working and it's not just using one small part of it and the rest is kind of slowly but surely withering away. So the community ties, the social ties, faith-based ties, reading, learning new skills, exercise, balanced diet, all the stuff that I'm talking about, how much do you think most of those things cost?
$0.
Very, very, very little, if not nothing at all.
Or you might pay some dues.
Right.
You know.
Something simple, right? But that's why a lot of people think, hey, well, what do I need to buy? What do I need to go and purchase? A lot of it is nothing. It's you doing stuff that you hear us talk about on the primary care side all the time. And I'm specifically speaking to George right now. As much as we have a conversation about medicine, most of the time I'm telling you, you need to get up, you need to get active, you need to get out, you need to do things that are going to literally keep you young, keep you healthy. And a lot of times people don't want to hear that because it's easier to do what? Take medicine. It's easier to swipe. It's easier to get stuff in a video format and not have to read it.
I feel like we've been programmed to do that. Number one, we've been programmed for instant gratification. So a lot of times taking medicine, swiping that card, even though that's like my least favorite activity. I hate spending money. But like swiping that card, it's instant and you're kind of done with it. That kind of reminds me of that conversation when, you know, I was feeling terrible at a convention and I called you and you was like, did you eat?
Yes. Yeah.
And I was looking for a pill, but you was like, did you eat? Did you sleep? Take care of yourself.
Yeah.
You know what I mean?
Yeah.
But I think that's just the way we're built in 2024.
Yeah. It's wired to go and not rest. Because for some reason, rest seems like a problem. Rest seems like a weakness. Rest seems like an ailment, but what it actually is your body recovering and replenishing. Now, when you're resting, that doesn't mean you need to sleep the whole time. You can rest and go read a book. You can rest and do some puzzles. You can rest and go do a healthy activity like walking around the neighborhood. Those are technically rest filled, but people don't think about that as rest because if I'm walking, that's not resting. So
it's not physical rest.
That's the point.
It might be mental rest.
It might be mental rest. But that's why I said some of these things that are not necessarily the true definition that most people are hearing when we say rest, it's almost like you have to take somebody and give them a very well written out plan on how to do things when some of it is very simple. It's don't overthink it. Do things that allows your brain to feel better. And most people know when they feel better. Most people. Some people don't. But most people, when you say, how are you feeling? And a person really feels good, they're smiling. They have a different sense of how they're moving, how they're conversing with you. They're doing things in a way that allows you to know they're having a good day. Versus a person who's just getting by, a person who's really and truthfully not doing a whole lot. So the people who are getting by move, act, converse differently than a person who feels better. So when you feel better, do more of that. Right. And if you do more of that, believe it or not, your brain is healthier. If you're sleeping more and you feel better, do that. If you're sleeping a lot and you don't feel any different, maybe sleeping is not the problem.
It's not the problem.
Right. Maybe you need to consider being active. Hey, I went and actually walked on the treadmill and I started reading while I was doing that at a slow enough rate where I wasn't going to have an accident and I felt better. Maybe you do more of that. Hey, I got on a bike and I rode the bike a little bit. I felt better. Do more of that. The problem is we have to think in the terms of what helps me feel better instead of, well, let me go and get on a program and I got to pay all this money. And you don't have to do all that. Whatever that feeling better is, if it's playing cards with your friends, do that. If it's literally going and socializing with your friends and it's not going to break the bank and it's not going to cause other bad habits, do that. I had a patient who literally came to the office today and I said, well, what are you going to do? It's Friday. What are you going to do for your weekend? Y'all going to do anything fun? She said, me and my girlfriends are actually going to the mall. We're going to go walk around and window shop, not spend money. We're going to go look at stuff. Then we're going to go eat salads. And she said, that's literally been a while since I did that. And she was smiling from ear to ear. You would have thought that she said, I'm about to go and get on a plane and go to this expensive restaurant in another country. She said, I'm going to the mall. I'm not shopping. I'm window shopping. And I'm going to eat salad. And that was happy for her. And you know how old the lady was? 66.
They going to the Mall, Louisiana?
Mall, Louisiana. That's what I said.
I'm about to say, they ain't going to be in there long.
They ain't. But this is the point. For a 66-year-old, and again, I'm not taking away from anybody if you're in that age range, listen to this. That can be a physical activity. Mm-hmm. She's now with friends, so she's socializing. She's also potentially having to navigate, walking, going upstairs, all that. So that can be, again, having your brain getting stimulated.
True.
You're having to drive if you're a person who's driving. And then you're going to go ahead and have a healthy meal, all while you're being in an environment of support. That makes you feel better. Yeah. And that's the point that a lot of people don't think about. They think, well, I got to go and do fill in the blank to get better and healthier, when sometimes it's just doing something different that makes you feel better.
Yep.
So I think that's a huge thing that people will say that can be helpful. So prevention of dementia is simple. It's not perfect. It's not a one size fits all. If you do more jumping jacks, you're going to have I'm not saying that. I'm saying that the more stuff you do that helps you feel better, I think you're going to start to realize you live longer and you have a better, healthier, happier life. And I think that's important. So I will kick it over to George and have him talk to us really briefly about what does he think would be a good strategy at this point for somebody who's listening in, saying to themselves, look, I have a person that I have a concern for that may have dementia. What should I be doing at this point? Well, we've talked about risk factors. Mm-hmm. We've talked about what things can be done to potentially prevent or modify those risk factors. We talked about how to identify potentially the dementia or the concern for dementia, who to go to and see them, to have them seen and have an evaluation. And we also talked about the prevalence of where and how many people have it. So what would you say a person who's sitting and listening at this point should consider doing if they have that concern after we've laid out all that information?
So for me, if it were my loved one, and after listening to all this information, I would keep a journal. I would keep a journal, and I would take notes about every time I visited that person, and I would try to see if there was any irregularities. You know what I mean? And I would just encourage that person to do things that empowers them health-wise, right? Mm-hmm. So like you just mentioned, walking around the mall or maybe doing something challenging mentally and just observing that person, you know what I mean? And if I was really getting concerned about what I was seeing, about the results, then I would take them to, the primary care physician, which would probably be you. You know what I mean?
Right.
So, and have those real conversations. But, encourage them to eat well, support them, maybe do something physically, do something mentally challenging with them, and just keep track of, your thoughts for every visit. Mm-hmm. and just notice patterns. If everything is just regular, that person could just be evolving. Sometimes change is a good thing, right? But if there's some things that you notice that may be problematic and is consistent, then say something.
Yeah, absolutely. And if you're a patient listening to this, there are simple things that you can do besides obviously having a caregiver or a family member help you out. It's simple stuff, trying to keep a daily routine so you're not having to navigate too much confusion all at once and navigate new tasks and activities all at once. So keeping a daily routine and adding a little variety in here and there, but not doing 45 different new things all at once is a huge thing. Memory aids are important. So that's things like calendars. Sometimes there are apps. As George mentioned, having a journal, jotting things down and having a to-do list and sticking to that list, that can help with, again, keeping your mind sharp to where you're not having to literally venture off the beaten path and redo or overdo things to a point where it just starts to get frustrating. And the very last thing, as George mentioned, engaging in exercise, right? As much as it sounds crazy, physical exercise helps with a lot of stuff. It doesn't mean you have to go run a marathon. It doesn't mean you have to go to the gym. It doesn't mean you have to be on a treadmill. It's getting out and doing things that are physically active that will help to stimulate you, stimulate the brain, and stimulate things in your body that are going to make you feel better, to where all of a sudden you say, you know what? I'm actually going to continue to do this because it helps me feel better, and I'm actually able to be more productive and be a lot more sociable because I'm now physically active. And I think that's important. Other things for the people who are caregivers that are listening to this and have an idea of what should we be doing to help support people who may be in the household or maybe family members that need help with this potential topic of dementia. So things you can do, again, encourage them to be independent, but also be mindful of not giving them too much of the independence to where you're now saying, hey, you can do everything by yourself, but I do have this concern that something's going on. You want them to remember to do things. You want to set them up for success, but just don't overdo it, right? So if you're giving them small, simple tasks to do and they're able to do it, keep that in mind, that that's progress. That's helping them, and that's hoping that they're going to continue to use that progress and be more motivated to continue. And as I mentioned, that could be doing those puzzles, right? You're giving them puzzles, telling them to do it, and seeing if they actually can start and finish the task. If they do, keep encouraging that and keep finding more puzzles for them to do. Don't give them one book of puzzles or one set of crosswords and then just say, well, they did that, well, I guess they're okay. You need to keep doing that, just like a person who continues to work out. They need to continue doing that to help that longevity and keep them going in that regular trajectory of being healthy and happy. Simplifying tasks is another thing. So giving them a list of things that are not only doable, but make it simple. As we just talked about, asking them simple, small things in a mini mental status exam can be helpful. So giving them simple tasks can be done as well. And then, of course, for you as a caregiver, you need to seek support. If you are at a point where you are literally doing everything by yourself and having to deal with someone who has dementia and you don't have a support system or a support group, it can be exhausting, it can be troubling, it can be challenging, and it could be to the point where it's all but defeating. So we want you to have that support system. And there are a lot of them. There are ones across the country that are in the same demographic, oftentimes as you. So if you're a person who's dealing with someone who has Alzheimer's, there are a lot of Alzheimer's support systems and support groups that can be out there that can not only be local, but maybe even national. Some that are online, some that are possibly phone-based. And all of these people are there to say, this is what you need to be doing, as opposed to you having to do it all by yourself. So that support system is there, and it's going to be huge, and we want people to really and truthfully know that is a thing. And if you have that support system, whether it's a local support system or a national, whether it's online or in person, it's better than you doing everything yourself. And if you can do those things, I think you will be a lot better off than just saying, well, I'm doing everything I can. I'm giving them puzzles. I'm trying to keep them active. I'm trying to keep them engaged, but I'm exhausted and I don't know what else to do. Believe it or not, if there's a place where you can take a break and that person still can be in a safe, secure environment and still be independent, still be healthy, still be social, still be physically active, and you get a break, you're going to do better. And if you're doing better, they're doing better, everybody's doing better. And I think that's helpful. Now, the last few things we'll talk about is there are medications that you can potentially use and possibly give to people for things like dementia, for things like memory. Again, we're not going to spend a ton of time on that because we don't want to get to the point where this is an overly medical show where you hear me, Dr. Jasper, say you need to take this medicine.
Right.
That's not a good idea, because if I don't know you, I don't know anything about you, and I don't know anything beyond that a person has dementia, nothing about their age, their family history, the medicines they take, their environment, me telling you what medicines to get on is not a good idea.
That sounds like a good way to get sued.
Absolutely. That's the other part. And I know malpractice insurance very well, and I know enough to know I don't want to use it.
Right.
So based off of that, we want you to get in care with someone. So if you're considering medication, you have a good evaluation, you have a good person who can give you the right meds at the right dose with the right length of time to know if it's working or if it's not, and then to refer if they need to. Not just medication, and none of the other stuff we've talked about, which is oftentimes the better approach, which is, again, less drug-to-drug interactions, because we talked about polypharmacy on the last episode.
We did.
Less issues with you having costs and overspending on things that aren't helpful. And then, of course, having all that being done and then just going backwards. So doing medicines is not something we're going to spend time on, but know there are medicines that can be used in dementia, in memory, in things that may help the patient either slow down the progression of the disease or at least address some of the gaps that are actually showing themselves. And all of that being said, what else are we going to say? Well, we're going to say that the big thing is doing this in a direct primary care setting allows us a lot more time to spend talking to you about dementia, to spend doing a mini mental status exam. to talk about health related activities and support groups, and to literally talk to you and your family in a way that allows you all to find a good solution for you. Not the one size fits all that you're seeing that your friend is doing and you think that's great, but then you realize you can't do that because your insurance is different and theirs is literally giving them coverage that yours doesn't. We want you to be in a setting where you come in and you say, hey, I had time to find a really personalized solution for me, my family, my setting that allows me and my family members to grow and to thrive. And I didn't feel rushed. I didn't feel like they were giving me a short answer and rushing me and telling me to come back. They really took their time during the exam and even after, giving me more information and more information and more information.
Yep.
So I think overall, if you're in this space, you're listening to us and you've gotten this far through the episode, hopefully you've gotten some idea that dementia is a thing.
It's a real thing.
It's a real thing. It affects a lot of people.
Yeah.
It doesn't have to be where you're older into your 60s or 70s and that's when it starts. It can happen even earlier than that. There's early onset dementia that can happen in your 40s and 50s. But if you're now moving in a space where you're saying, I'm in primary care, I'm now knowing what to look out for. I kind of know when I need to start having those warning signs go off, and then I know what to do next, which is get that person in for an evaluation and then talk to them about how to actually get a proper diagnosis and proper treatment. You should be better off at this point. And I think if you're better off at this point, that allows you, myself, and other people around you to kind of say, look, we're in a good space. So George, anything that you'd like to give the people in terms of your take home points for today?
So my take home point is I got two things I want to say. Number one, it's similar to what I say every week, right? You notice something, you say something. You know, you are responsible for your own health, not your doctor, not your insurance company, not anybody else, right? Now those things are tools in your health, correct? But you're responsible for your health and your loved one's health. So pay attention, use these things like the podcast, your doctor, as resources to where you educate yourself and take charge of it. And if you need some help, get the help. But it starts with you paying attention to the symptoms and what's going on with you and your loved ones, right? Second thing I want to say is kind of a little unrelated, but I got this notification. I don't know if you could tell I was quiet for a little while. Greg Gumbel, the great broadcaster, older brother of Bryant Gumbel, the first black journalist to do a play-by-play championship. Big guy in sports media, dude I looked up to when I was a kid. Kind of fueled some of my passion to do some media. He passed away today.
I'm sorry to hear that.
So that was one. But I just wanted to, as a pioneer in the media, somebody from New Orleans, Louisiana. I just wanted to give him his flowers, and it's unfortunate. Our thoughts and prayers are with his family.
Absolutely.
Is that's a big loss for me. So I just wanted to kind of announce that and give him some props.
Yep. So I think to venture a little bit back to the topic, I think my take home point is that dementia is complex. It's not something simple. It's not a one and done thing and a one size fits all. There are different cases, different levels. One thing we didn't talk about is who's more likely to get it, males versus females. Females are more likely to get it. I didn't say that earlier and I apologize for that. And another risk factor that sometimes happens is education level. So those that have a lower education level, oftentimes as they get older, are more likely to develop this versus those who have a higher education. So those are all things you won't know unless you're in care with someone who really understands and knows all this information. There's only so much we can pack into an episode, and there's only so much we can do that is very broad strokes that we can paint with. If we're very specific, very detailed, it eliminates so many people who may be listening that we don't want to do that. So we try to keep things very generic and also very generalized for people to be able to apply it, hopefully as a place to start in their settings and in their care. And with that, I'm trying to say in so many words, you have to be very mindful that these things are going to be different. They're going to be unique to you, your family, your caregiving, your caregiver. All of these things are going to be to where you should be in care with someone who is engaging with you in a way where you know it's about you and it's not about your insurance. It's not about what's covered. It's about those things in a way that is very helpful. So all of that being said, I need to slowly kick it over to George and let him slowly close us out. I actually have a call for my patient, and I'll say, I'll see you all in the next episode. But George, let the people know where they can find us and find you.
Good deal. So you can always find me at on X at George_Becnel. I'm on LinkedIn at George Becnel, George P. Becnel II. I'm also on Instagram at Becnel Media. You can also find the clinic as well. You can find the clinic on Instagram at Byja Clinic. That we're also on LinkedIn. We're on Facebook and all of social media platforms. So, and if you haven't read the Byja Blueprint, go out and get a copy of that. That's on Apple Books. It's on Amazon. It's on all the major platforms. Barnes & Noble got it, all this good stuff. So please look for the Byja Blueprint book. And please continue to like, subscribe, and share these episodes with a friend. And we will see you next week.